Hello class, welcome to Flourish Nursing Academy. I am Tutor Godwin. We will be talking about varicocele. Varicocele is the dilation and tortuosity of the pampiniform plexus and also of the testicular veins. Seen commonly in men aged 15 to 30 years, it occurs in 15 to 20% of all males and 40% of all infertile males. Normal small vessels of plexus 0.5 to 1.5 millimeters. Diameter greater than 2 millimeters, varicocele. EDIRHC primary, due to incompetent valves, 98% occur on the left side. Secondary, red flags for secondary causes. Acute onset in older men, right-sided isolated varicocele that does not decompress when supine. Evaluate for retroperitoneal renal mass or venous obstruction, e.g. renal cell carcinoma, IVC obstruction. Pathophysiology. Venous backup. The primary cause is an obstruction or failure of the valves in the internal spermatic vein, causing a backup of blood and venous engorgement. Left versus right side. The left side is more commonly affected because the left internal spermatic vein drains into the higher pressure left renal vein, whereas the right vein drains directly into the inferior vena cava. Nutcracker effect. On the left side, compression of the left renal vein between the aorta and the superior mesenteric artery can increase pressure, further impeding blood flow and leading to varicocele. Effects on testicular function. Impaired blood flow has several detrimental effects on the testicles. Increased temperature. Blood pooling raises scrotal temperature, which is detrimental to sperm production, spermatogenesis. Hypoxia. Reduced blood flow can lead to oxygen deprivation, hypoxia, within the testes. Oxidative stress. The condition increases the production of reactive oxygen species, ROS, which can cause DNA fragmentation in sperm. Consequences for sperm. The cumulative effects of increased temperature, hypoxia, and oxidative stress lead to a range of sperm abnormalities. Decreased sperm concentration, decreased sperm motility, movement, abnormal sperm morphology, shape, reduced sperm DNA integrity. Ultimately, this can result in male infertility, clinical manifestation, visible and palpable signs. Bag of worms feeling. A larger varicocele may appear as a collection of swollen, twisted veins in the scrotum, often described as a bag of worms. Scrotal swelling. There may be a general swelling or bulge in the scrotum. Differently sized testicles. The affected testicle may be noticeably smaller than the other, a condition known as testicular atrophy, especially in adolescents. Pain and discomfort. Aching pain. A dull, aching pain or a feeling of heaviness that worsens after standing or exercise and improves when lying down. Location. The pain is typically felt in the testicle or on that side of the scrotum and can be aggravated by hot weather. Infertility. Reduced fertility. A varicocele can lead to infertility because the enlarged veins may raise the temperature of the testicles, affecting sperm production. Abnormal semen analysis. This can result in a decreased sperm count, poor sperm motility, movement, and an increase in abnormal sperm forms. Detection. Physical examination. Many varicoceles are detected during a routine physical or when a patient seeks an evaluation for infertility. Asymptomatic. A significant number of varicoceles do not cause any symptoms and are often found incidentally. Varicocele and subfertility. Altered heat exchange mechanism to stagnation, hyperthermia, inhibition of spermatogenesis. Increased temperature, increased metabolic activity, depletion glycogen storage, injury of the parenchyma of the testis, oligospermia. Neuralgia, Leydig cell dysfunction, low testosterone. Grading. Grade 1, palpable only with Valsalva. Grade 2, palpable without Valsalva. Grade 3, visible through scrotal skin. Subclinical, only on Doppler ultrasound. Differentiate from testicular torsion, emergency, sudden severe pain, high riding transverse testis, absent cremasteric reflex, nausea, vomiting. Epididymitis orchitis, pain with fever, dysuria, relief with elevation, Prin sign, tender epididymis. Hydrocele, painless swelling, transilluminates. Inguinal hernia, groin scrotal bulge, increases with Valsalva, reducible. Diagnostics investigation, scrotal ultrasound with color Doppler, if exam equivocal, or for adolescents and pre-op planning, shows dilated veins and reflux. Semen analysis for infertility evaluation. Consider renal imaging if right-sided or non-reducible when supine. Common nursing diagnoses: acute pain or impaired comfort related to venous distension and inflammation. Risk for impaired fertility related to testicular thermal stress and impaired spermatogenesis. Anxiety deficient knowledge related to diagnosis, fertility concerns, and procedures. Risk for infection and bleeding related to invasive procedures, surgery embolization. Disturbed body image related to scrotal changes. Conservative management. Symptom relief. Scrotal support, supportive briefs, athletic supporter to reduce venous pooling. Activity modification. Avoid prolonged standing, heavy lifting, and high-impact activity that worsens pain. Local measures. Intermittent cold packs 10 to 15 minutes for pain flare-ups, protect skin. Pharmacologic. NSAIDs or acetaminophen as ordered. Screen for contraindications. Administer with food and monitor GI renal risks. Bowel regimen. Hydration, fiber, stool softeners to avoid straining that increases intra-abdominal pressure. Monitoring. Track pain scores, triggers, and response to supportive measures meds. Adolescents. Serial testicular measurements, orchidometer or ultrasound to detect 20% asymmetry or growth arrest. Indications for intervention. Teach, anticipate. Persistent pain despite conservative therapy. Infertility with abnormal semen parameters and palpable varicocele. Adolescents with decreased ipsilateral testicular size or growth arrest. Cosmetic psychological distress after shared decision-making. Pre-op. Verify consent, NPO allergy history, and medication reconciliation. Hold anticoagulants, antiplatelets per protocol. Baseline pain, vitals. Shave skin prep per facility. Patient education, procedure, anesthesia, expectations, recovery, fertility timeline. Post-op, pain control, NSAIDs, acetaminophen. Consider short-course opioids if ordered. Assess pain regularly. Ice packs and scrotal elevation support for 24 to 48 hours. Incision care. Keep clean dry. Remove dressing per order. No soaking, baths, pools until cleared. Shower usually after 24 to 48 hours. Activity. Light activity as tolerated. Avoid heavy lifting, strenuous exercise, and sexual activity. Typically 1 to 2 weeks. Follow surgeon guidance. Monitor for complications. Hematoma, wound infection, fever, increasing pain, swelling, new onset large, scrotal swelling, possible hydrocele, signs of testicular ischemia, increasing severe pain. Patient education, when to call, fever, 38 degrees, purulent drainage, uncontrolled pain, sudden severe scrotal pain, inability to urinate. Percutaneous embolization sclerotherapy, interventional radiology. Complications to monitor: recurrence, persistent varicocele or pain, hydrocele formation, new fluctuant swelling that transilluminates, wound infection or hematoma. Very rare: injury to the testicular artery, testicular atrophy, DVT, or embolic events after IR procedures. Fertility and psychosocial care. Education: varicoceles may impair sperm production and quality. Repair may improve semen parameters over 3 to 6 months. Conception may take additional time. Semen analysis is typically repeated at 3 and 6 months post-repair. Encourage evaluation of both partners in infertility. Adolescents, young adults. Address body image, embarrassment, and activity limitations. School sports notes if needed. Guidance on supportive garments during sports. Lifestyle. Maintain a healthy weight. Avoid overheating testes. Very hot tubs, laptops on lap for long periods. Manage constipation and limit heavy straining. Patient and family education. Condition basics. Usually benign, common on the left. Symptoms often improve with support and rest. Self-care. Wear supportive underwear. Use ice intermittently for pain. Take medications as directed. Avoid prolonged standing when symptomatic. Proper wound or puncture site care. Keep area clean, dry. Avoid soaking. Warning signs requiring urgent care: sudden severe scrotal pain, swelling. Rule out torsion. Fever, purulent drainage, rapidly enlarging swelling, inability to reduce swelling, and wound bleeding that won't stop with pressure. Right-sided or new-onset non-reducible varicocele, especially in older men, warrants prompt evaluation. Return to activity, sexual activity timelines per provider. Contraception, fertility planning discussion as appropriate. High yield points, classic finding, bag of worms on standing exam, improves when supine. Left-sided predominance, isolated right-sided or non-reducible varicocele requires evaluation for secondary causes. Differentiate torsion, sudden severe pain, high-riding testis, absent cremasteric reflex, emergency. Initial management, scrotal support, NSAIDs acetaminophen, activity modification, bowel regimen. Indications for repair, persistent pain, infertility with abnormal semen analysis, adolescent testicular atrophy, growth arrest. Post-op IR priorities, ICE, scrotal support, activity restriction, monitor incision hematoma, teach when to seek urgent care. Hydrocele is a common post-operative complication. Monitor for new transilluminating swelling.